I'm going to talk about brain tumor imaging. Okay, how many people are reading brain tumor in their practice? How many people are attending tumor board for brain tumors in their practice? Yeah, okay, so this is going to be some helpful tidbits for that. There's one thing I wanted to I forgot to mention it this morning about head and neck cancer. Okay, there is a lab that the big institutions are running called NavDx. NavDx is, guys, the next generation of follow-up testing. It is getting DNA of HPV positive cancers in the blood. So these are what we're calling blood biopsies, and you're going to see this more and more emerging now, to the point where if the imaging is negative or borderline for a lymph node or something, they're getting NavDx and treating accordingly. It will show you recurrence. Very, very sensitive and very specific for recurrent squamous cell carcinoma for HPV positive patients. So you're going to start seeing a lot more of these blood biopsies for cancer. In fact, there's a lot of companies offering, blood tests, and will tell you what kind of cancer you have or at risk for what type of cancer you have. There's a whole panel of things that some companies are running now, but NavDx is really the only FDA-approved blood biopsy for head and neck cancer right now. So if you're in head and neck tumor boards, you can mention NavDx to your clinicians and say, are you using this? How regularly are you using this? But it's an interesting thing. So now I run into the postprandial brain tumor talk. Okay, this is a dangerous point for me right here. And listen, if you want to doze off, I'm not offended, okay? So here we go. Now what? We see this. What are we going to do with it, okay? So this is how we can be helpful, guys. I'm going to talk about the initial diagnosis of brain tumors and masses, some perioperative period stuff, and some follow-up. So I want to be helpful in all of these stages of a brain mass, okay? So we talked a lot about anatomy already, but I just want to emphasize the fact that, the pachymeninges and the leptomeninges that Dr. Sminiotopoulos talked about, the pachymeninges, they divide up into the periosomembranous portions. Then you have the arachnoid layer and the pia and the subarachnoid space and the arachnoid granulations, okay? So basic stuff, again, we're talking about the arachnoid, pachymeninges, leptomeninges. When we talk about a lot of this stuff, the embryologic precursor is called the meninx primitiva. Why do I mention this? Well, that outer layer and the inner layer that we talked about, the outer layer is mesenchymal origin, it forms the dura. The inner layer, which I'm very interested in, is neural crest origin, okay? That forms the pia, arachnoid, the leptomeninges. And why do I say that? Because some very interesting things can happen from that neural crest derivative, okay? Intraaxial, obviously within the pia, like we talked about. Extraaxial is outside that. But because the leptomeninx is derived from neural crest cells, we get some crazy stuff in the brain. Like, why would we get a lipoma, like a big fat mass in your brain, right? Well, that's a neural crest derivative. Why do we get melanoma in the brain? Well, neural crest can dedifferentiate into melanocytes, and you get neurocutaneous melanosis. Like, you got to ask yourself why things happen sometimes, and there's definitely an embryologic reason for those things. So lipomas, melanosis, arachnoid cysts, they can be derived from neural crest tissue in the leptomeninges, and that's why you're going to end up with some of this stuff. Listen, the size of a mass can be very confusing sometimes because is it intraaxial, is it extraaxial? There are some ways to try to differentiate that. The nice CSF cleft between the mass and the cortex that you see here, inward displacement of cortical vessels, dural enhancement, skull invasion. Some of these clues will help you on whether a mass is intraaxial or extraaxial. That's sort of the basic compartmentalization of that. So most common extraaxial mass, we know this all day, right, guys? The meningioma. There's certain reasons you get meningioma. Meningiomatosis, you're just a meningioma former. NF2, previous whole brain radiation. Schwannomas, other extraaxial masses, some angioparasitoma. That's a little bit of an old phrase now. We're not really using that anymore. One thing I will say about previous whole brain radiation, guys. So in women or that have breast cancer or lung cancer patients, they can get dural metastases. And they may have had whole brain radiation in addition to that because they had a MET. Be very careful in those patients to say, oh, that's a meningioma secondary to whole brain radiation, when it was actually a dural MET in a patient, okay? So that you want to get short-term follow-ups. You really want to watch to see if this thing is growing or not. So be very careful in patients that you had whole brain radiation. Don't come down hard on meningioma necessarily because it could be a dural metastasis, okay? Other things that cause extraaxial lesions, there's a whole laundry list of things that you'll have. Here's the classic meningioma, dural tail. You know, the dural tail enhances slightly more than the actual mass. That's a little sign there. I look for hyperostosis as well. Most common tumor, intracranial neoplasm, arises from arachnoid cap cells. This is always like very nerve-wracking to do this in front of Dr. Smirniotopoulos because he's like, this guy's a total idiot. None of this stuff is true anymore. Didn't I teach you better? So, Jim, if you could just hold this until dinner to tell me how dumb I am, I'd appreciate that. So, supranatorial, 90% of cases, extraaxial mass with dural base attachment. So, 90% enhance homogeneously, calcification at 20 to 25%. This is another little morsel you can give to your neurosurgeons. We talk about sort of texture analysis, and we use T2 weighted imaging for that. And I'll show you what that means in a second. But the lower the meningioma is on T2, the harder it is on for them when they excise it. So again, look for that CSF cleft, the dural tail. There may be some vascular flow voids. Hyperostosis, guys, you can see this in other lesions, so don't necessarily rely on hyperostosis. You can see it in prostate mets and lymphoma. You can have peritumoral. This is sort of a little bit mind-boggling for people. How many of you had cases of meningiomas that have a lot of intraaxial edema? Like in the brain, I mean, and you're like, okay, so there's thoughts and there's a lot of papers to say, okay, it's only the higher grade tumors that do that, right? So I should be more worried about a meningioma that gives me a lot of edema intraaxially. Those thoughts have been a little bit debunked, okay? We're sort of thinking it's based on the histology. So you can have different histiotypes of meningiomas. Something called the secretory meningioma has a higher propensity to have intraaxial edema. So it's more based on the actual histological makeup of the meningioma, the type of meningioma, than necessarily the grade of the meningioma. So don't freak out if you see intraaxial edema with this extraaxial mass. It just may be the type of meningioma that it is, because there are various subtypes. And on MRS or spectroscopy, you'll see elevated alanine. That's another way to differentiate. If you have a diagnostic dilemma, by the way, between the breast met and meningioma, you can do spectroscopy and that will help you with the elevated alanine, okay? Slow growth, surgical resection considered for patients that have this growth over time. They're symptomatic or asymptomatic patients with easier access. Other things to consider in the cerebellopontine angle, which you're going to see meningiomas in, are schwannomas and epidermoids. Classic examples of vestibular schwannomas, or that ice cream cone lesion. Here you have NF2 with bilateral vestibular schwannomas, sort of an Aunt Minnie there. Arachnoid cyst, that does not have reduced diffusion. Epidermoid cyst, you see the reduced diffusion on the DWI. That's the way to differentiate those two. So what is our role, guys? Define the extent of the entire tumor, location, invasiveness, encasement of vital structures. And when you see these cavernous sinus meningiomas, are they encasing the ICAs? Are they encasing vital nerves? Are they encasing vital structures? That's what you want to tell your neurosurgeons, okay? If you can make a suggestion about consistency, that's pretty helpful for them, right? So it would differentiate softer tumors, which can be done from keyhole versus sort of like a larger surgery, right? And you can bring the possibility of an F2. Here's a great example that was in this paper about the T2 consistency. Everything looks relatively the same on the post-GAD, guys, but look at the difference in the T2 weighted image of this one and this one. One is much darker. This is going to be a lot harder on resection than one that's much brighter, which is going to be a lot softer on resection. Why does that make a difference? If this stuff is near the falx or the superior sagittal sinus and you have to really carve this thing out, you want to be very careful of injuring the superior sagittal sinus in that type of situation. So if you can make a suggestion about consistency based on the T2 weighted images, that's kind of helpful for your surgeons to think about. Other things that are extraaxial and homogeneously enhancing, you can see lymphoma here. You see how dark that is, but look at that non-contrast, that head CT, hyperdense because of the cellularity. So that's a nice, helpful hint. Dark on T2 and heterogeneously enhancing. Other things, solitary fibrous tumor, EB-related leiomyomas. I mean, you would never call that, but just know that it exists, right? Other extraaxial apostases, the Erdheim-Chester, neurosarcoid. We had, intracranial hypotension. We talked about this. Some great talks on that earlier today. So just think about that when you have dural enhancement or dural-based enhancement in that way. Okay, how can we be helpful with the initial diagnosis, guys, when we're looking at brain tumors? So number one is know your patient. Why do I say that? You want to know if this is an acute onset neurologic deficit or slowly progressing neurologic deficit. Age makes a significant difference. Listen, if you were to tell me the symptom and the age of the patient, I don't have to look at a single image and I will give you the differential of the brain. Just give me the symptoms and give me the age, and I'm going to give you the top 3 or 4. One of those is probably going to be right, okay? Is it a mimic? Is there any high-risk anatomy involved, and are there imaging biomarkers, which we'll talk about? So again, guys, these QR codes are there. This is a great webinar by Raj and Jane at NYU. It's a 30-minute, 45-minute talk. It's amazing. So there's the QR code for that. Know your patient, age and gender, presenting symptoms, and time course of symptoms, and you're going to have a pretty good differential based on that. For peds, a little bit different. There's certain types of pediatric tumors. I'm going to get into the molecular classification in a little bit. So they usually present with seizures. The time course is usually subacute onset of neurologic symptoms for peds. If they have these 2 distinctions to be made, it's either BRAF or they're histone tumors. BRAF is much better. H3K and H3K27 much worse, and I'm going to show you examples of that. Adults, if it's a young patient, again, these are the molecular classifications I will talk about. They're usually asymptomatic for younger patients, headache or seizure. If they are GBMs, by the way, this is a GBM, and I'll talk about that later, it's usually subacute neurologic deficit. They are having some deficit over the course of weeks. They did not show up in the ER tonight with something wrong. Okay, but if they show up into the ER and this guy's been slowly deteriorating over the last weeks to months, now you're actually more worried about a GBM than they would have said, oh, he just got hemiplegic. That's not how GBMs are going to present. You're much more worried about a brain tumor with slow progression. Okay, subacute presentation of neurologic symptoms. So that's what you want to keep in mind. Is it a mimic? Okay, so there are a lot of things that are not brain tumors that can mimic brain tumors, right? So infection, demyelination, vascular disease, radiation necrosis, subacute ischemia. I'm going to give you examples of these. 25-year-old MVA, hyperdense lesion. Look at that susceptibility weighted image. That ended up being a cavernous malformation in this patient. Okay. 28-year-old with paresthesia. We don't have maybe we do, but a demyelinating talk that encompasses this, but this is tumefactive MS, all day. It's that incomplete horseshoe rim of enhancement, right, towards the ventricle. So not a tumor. There's a couple things you don't want to biopsy on the slide are like MS and stroke. You don't want your pathologist telling you that, right? It's a little bit of poor form to biopsy those. So you want to be sensitive to this stuff. Other things here, 31-year-old with eclampsia and head bleed. She had this head bleed here. This was her 3 hours before, right? If you look at this patient, head bleed here, there's some hyperdensity here. This ended up being an AVM that bled, okay? So sometimes there's some hints, even on the non-contrasted CT, that there's something else that caused that bleed, okay? Central pontine myelinolysis here, classic example of that. Diffuse cerebral edema, this is not hemorrhage, right? This is pseudo subarachnoid hemorrhage and pseudo subdural hematomas in a diffusely edematous brain. You have PCA infarcts that can cause edema, and obviously that's stroke there. Big MCA infarct here, things that cause edema. You can see that on the diffusion, a little bit of microhemorrhage associated with that. Okay, this is the tricky one. Please watch this. So we have a lesion here. They showed up in the ER, and you end up with that on the post-GAD. Here's your DWI, here's the flare, here's the susceptibility. Is this a tumor? No. And how do you know that, guys? So Girish Fadapaker from NYU, this is his big campaign with brain tumors. If the flare matches the DWI, it's a subacute stroke. This is a enhancing subacute stroke. You would expect with a brain tumor, guys, there to be a lot more edema that's outside the area of diffusion. A lot more vasogenic edema associated with this. If there is a flare diffusion match, this is going to be a subacute stroke. They have to be included in your differential and not brain tumor. Again, you should expect a lot more vasogenic edema with a brain tumor, either a MET or a primary tumor. Okay, so please keep that in mind, okay? So again, a lot of rim enhancing stuff may not be a tumor. We saw some great examples of brain abscess. This is that subacute infarct, tumefactive MS, and this is toxo. So rim enhancing stuff is not slam dunk brain tumor. Jim loves this case. I mean, enhancing lesion, very worried about this thing, right? We saw it maybe a week later. What was the initial diagnosis? This is a hematoma that ended up being rim enhancing. So if you have the access to priors, that's amazing, right? So even hematomas will ultimately show enhancement. We know that, okay? This is a great paper by Soon-Mi Cha and the UCSF group, as you know, and talking about mimics and the MR findings that can help you identify tumor mimics, okay? Know your imaging options. Will conventional imaging suffice? Do we need to do any advanced imaging, and what other modalities like PET may help you? So that's part of the brain tumor imaging continuum there. Know your neuroanatomy, right? So if you can identify things like mass effect and herniation, obviously. Does the brain tumor involve eloquent areas of the brain? Who knows what the definition of eloquent area of the brain is? This is areas that are responsible for activities of daily living, right? So the motor strip, primary sensory strip, things like that. Surgeons are going to want to know that because a resection of that will cause significant deficit in patients. So if you can say, yes, this involves the motor strip or primary language areas or sensory areas, that's important. Are they encasing vessels and nerves? That's going to be a dissection dilemma for them, and a resection dilemma, I should say. And, are there big veins that are overlying this? You can see that on your post-CAD T1s. Like there's a massive vein of Trillard overlying this tumor, so you want to be aware of that, right? So if you know your neuroanatomy, that's helpful. We're coming into an era of imaging biomarkers, guys, and what does that mean? Are there imaging findings that would be highly suggestive of the type of brain tumor that we're dealing with that might help with prognostication? Imaging biomarkers. And I'm going to show you some of the most validated. There's really one most validated imaging biomarker that we are looking at. AI is helping with this significantly, right? Because AI is seeing features of tumors that we can't really perceive. But imaging biomarkers is the next wave for radiology, especially in neuro, okay? Because, by the way, we used to say if it's necrotic, it's a GBM. No more, right? A lot of tumors can be necrotic, but it is all dependent on what we call the molecular profile, which I'm going to talk about. So again, what can you report, guys? Findings supporting a tumor diagnosis, you can lean one way or the other. This does look like a tumor. Actually, this looks like MS. This looks like a subacute stroke. High-risk neuroanatomy and possible diagnosis based on imaging features and biomarkers, which we'll talk about. Time for treatment. I know that's nasty, I know, but I actually YouTube neurosurgery videos so I can see the resections and the evacuation of subdural hematomas. So in my free time, I just watch neurosurgery on YouTube, which is sad. I know. Okay. So how can we be helpful in the postoperative period? Okay, so now we made the diagnosis of a brain tumor, right? They have resected it. Now, how can we be helpful postoperatively? So this is very important. So 18% reactive enhancement when imaged under 48 hours. 45% reactive enhancement when imaged after 48 hours. So post-op day 0 imaging, we want it as close to immediately after the surgery as possible. The more we delay, it will enhance. The granulation tissue starts to enhance. So you are not going to know if there's residual tumor the more you delay, because we want to see if there's any tumor left with our post-CAD imaging. So if you can get it as close to the surgery as possible, you will be better off in your imaging, okay? Now, there's two things I really want to talk about with postoperative imaging, and that's extent of resection, is it residual tumor versus blood products, and marginal ischemia, two concepts I want to talk about. So this is a post-contrast T1 weighted scan showing T1 hyperintensity in the resection cavity. Okay, immediate post-op scan. Is this residual tumor? Well, I would not come down hard on this at all until you see what? The pre-contrast T1. So I made this mistake as a neuro fellow in front of the entire neurosurgery department. And I will never forget it. It's etched in my soul. Where I said in front of the entire neurosurgery department, and there's some residual tumor, and the neurosurgeon said, "I'm sorry, are you telling me I left tumor behind? Is that what you're telling me?" And I said, "Well, I think so." And he said, "Why don't you look at the pre-T1?" And I looked at the pre-T1, and it was bright, and it was just hemorrhage in the resection cavity. And he railed into me, and I will never forget it. So before you accuse people of leaving tumor behind, check the pre-contrast T1. And if it's bright, that was just hemorrhage in the resection cavity. Okay. 57-year-old male with new right-sided weakness and prenatal drift, intermittent confusion, and dropping objects. Check the pre-T1 again, right? So this is the post-op baseline. So this is actually a little bit of enhancement because the pre-T1 was not bright. Okay. Post-op day 20. Okay, now we're getting some more enhancement here. Okay, so just be careful on the pre. So if I'm getting enhancement further out, guys, this is why you always want to check your baseline study. What happened in this case? Now, post-op day 20, I'm having some enhancement around the rim. My post-op day 3 exam showed marginal ischemia. This ischemia will enhance 3 weeks out. So before we start calling recurrent, it's just like any stroke. I just showed you a subacute infarct that enhanced. It's the same thing we have here. They're taking out little veins. There's going to be some marginal ischemia around the section cavity. Do not call recurrent tumor until you've checked your baseline study that showed there's ischemia there. That will enhance, and that's normal. Okay, especially if they're on treatment, they're going to go on these trials, step protocols, this and that. You're telling them they failed treatment within a month when we didn't check that there's marginal ischemia on the baseline exam. So very, very important there. Okay, so check that for marginal ischemia. So my two big things here: check the pre-contrast T1 for blood, check for marginal ischemia. Report any residual flare, T2 intensity in the resection surrounding the cavity, and look for intracranial and extracranial surgical spill. So let's get ready for tumor board. Take a deep breath. I'm just going to show the Krebs cycle briefly. Okay, I know it's just after lunch, it's like the worst thing you can do. But the only point of showing this is something called IDH. So there's a pathway here in the Krebs cycle in which IDH is responsible for, creating alpha-ketoglutarate and whatnot. So if you have a mutation of IDH or IDH wild type, this is the only thing I want to show you. If you have a mutation of IDH, you spit out this metabolite called 2-HG. So there are tumors that have IDH mutations. There are tumors that have IDH wild type. Basic concept, right? So we can actually image 2-HG using spectroscopy. You get a 2-HG peak. So now I can tell my people this is an IDH mutant tumor. Why is that important? IDH mutant tumors do way better than IDH wild type tumors. Way better. They live 8 to 9 years, wild type 1 to 2 years. Okay? So, also has whatever. Let's just move on. The wild type's very bad. So I want to just get to the crux of this. Remember, you guys, when I told you this morning about lymph nodes and I said one phrase, morphology is king for lymph nodes, right? Not size. I'm going to translate this to brain tumors now. Molecular classification is king. This histologic diagnosis of, this patient's got necrosis or neovascularity or blah, 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 all that is secondary now. Tumor boards, and you may be experiencing this already, most of the discussion is molecular classification more than anything else. Just show us what the molecular classification is. It is completely prognostic, okay? So we get the histologic grade. What type of cell does this resemble? Does it resemble one of these? Okay, well, if it does, let's get the histologic grade now. Does it have these features? Now they're looking at molecular classification. That is king. It trumps everything, okay? So again, does it resemble an astrocytoma? Great. What kind of histologic features do they have? Great. Is it IDH1 mutation, ATXR? So when you read your path reports, guys, this is actually what they're doing, right? The histologic grade says, it's GFAP positive, confirming astrocytic origin of neoplasm. That's the histologic grade. If you look at the grade, it talks about hypercellularity, pleomorphism, cellular crowding, mitotic features. That's all histologic grade. What is it in the end? IDH1 is positive ATRX loss. That is the most important thing there. Then it gives you this integrated diagnosis of histology, molecular, and grade. This is a diffuse astrocytoma, grade 2 IDH1 mutant. This thing trumps it all, the molecular classification. But that's essentially what they're telling you in these reports. Why do we care? IDH1 mutation do much better, wild type do much worse. Okay? So these are the only two molecular classifications I need you guys to know. 1P19Q, by the way, is oligodendroglioma. They do even better. Okay? So you're looking at IDH1, and you're looking at 1p19q. Those are the only two I need you to know. Okay? So if you're going to be an oligodendroglioma, guys, you need both of these. You need IDH1 mutation, and you need the 1p19q co-deletion to be considered an oligodendroglioma. Period. End of discussion. I don't care what the tumor looks like on imaging or anything. End of discussion there, okay? We talked about imaging biomarkers. This is probably the only imaging biomarker that is agreed upon to be, some papers call this 100% specific. I mean, that's a big claim, okay? But 100% specific. So if you look at the T2 on a tumor and you look at the flare and the flare signal drops out with this hyperintense rim, this is an IDH1 mutation, non-co-deleted tumor. What does that mean? It's IDH1 mutant, but it's not an oligo, because to be an oligo, you had to have the co-deletion. So it's IDH1 mutation, non-co-deleted, which means they're going to live about 8 years. Okay? If it was IDH1 mutation co-deleted, they might even live even longer because it's an oligo all of a sudden. Okay? But if they have this sign, that's probably the most trusted imaging biomarker, and that's just summarizing it there. Survival's pretty good for that T2 flare mismatch. Wild type, no bueno. 2 years, okay, at most. So there's other biomarkers, other molecular grades. So again, we used to say low-grade anaplastic glioblastoma. All that is gone now. You're an IDH1 mutation, grade 2, 3, or 4. This nomenclature is done, okay, because you're all depending on IDH1 mutations now. And this is IDH wild type. They're all considered grade 4. There's some other things that they look for here, okay. Anaplastic GBMs, you know, all this stuff is gone. Gone, okay? Depends on the molecular markers now, okay? Necrosis depends on the molecular markers, okay? All this stuff, you know, because everything can look differently. I showed you a bunch of cases of that. This is unfortunately a 2-day-old with a GBM. You know, there's a bimodal peak. They can be very young, and then they can be in their 60s. This is just a Labrador Retriever with a GBM. I used to do, believe it or not, animal imaging. Will knows at Tufts, our PACS was connected to the vet school. So they would call our reading room and say, we have a dog here with a brain mass. What do you guys think? So we used to do the dog imaging. Okay. I know, weird. Perfusion, you know, we've talked a lot about perfusion in our days, trying to grade tumors with perfusion. You know, the more higher RCBV, the higher the classification. People tried to come up with actual numbers to say if it was above 1.75, it's a higher grade tumor. That all this stuff has its limitations. I'm not sure a lot of people are doing this, but what we do is we follow trends. So if something is getting worse on a perfusion basis, we get much more worried about it. If the perfusion staying the same over a lesion or coming down, those are always better. So we're looking at trends. This is just to show you that red is bad here. It's a higher grade tumor, okay? There's a lot of other imaging stuff that's in the research space that you hear a lot of great talks on, but let's just move on to what to do after surgery. Do you want to image early, image before granulation tissue forms, and there's going to be treatment-related changes. Some are called pseudoprogression, pseudoresponse, radiation necrosis. There are time frames for all this stuff, okay? Another imaging biomarker we've talked about is calcification. If you see calcification in a tumor, it may be an oligodendroglioma. I like to call these ugly dendrogliomas. They're a little bit more heterogeneous. They have some calcification, but not the best imaging biomarker, nothing like T2 flare mismatch, but some people have suggested if you see calcifications, it could be an oligo. But again, there are a lot of other things that calcify, guys. Okay, we just saw a great case of craniopharyngioma, Farr's disease, tubers, and ganglio. Just to let you know, there are other molecular markers out there. Don't need you to memorize this or get upset at me. This is just so you know. If something is P16 positive, they do much worse. All this stuff is much worse. And these are all going to be on your path report, okay? Other stuff, again, for kids, BRAF is better. These histone tumors, much worse. We used to call these diffuse midline gliomas. We're calling them histone. MGMT methylation, that's going to be on your path report. If they have this, that's better, okay? All this is by C-Impact now. Those are the grading systems for that, okay? So listen, Tumor Board is all about, you know, anticipating the questions, give them a goodie bag. This is why you're here, and this is why you know what you do. So follow-up imaging, treatments, standard treatment is the STUP protocol, guys. Gross total resection, whole brain therapy, and temozolomide therapy. There's a lot more stuff coming out for treatment, okay? Some of the newer therapies. I'm going to skip through that. So listen, we went through initial diagnosis, perioperative period, and follow-up. Know your anatomy. Familiarize yourself with two molecular markers, guys. IDH1, 1p19q. That's the bifurcation in brain tumor right now. Know the treatment course and know that. So complicated, but again, morphology was king with lymph nodes. Molecular markers are king right now with brain tumors. Okay? Complicated topic, but sorry.